And I'm David Kay. I'm one of the trainers with the Patient Navigator Training Collaborative, ably assisted today by Hannah Cruz,
Hello.
who is a Master of Public Health student at the School of Public Health studying epidemiology. She's a program assistant for the PNTC, and she's filling in for Aaron Martinez today, who's out of town at a conference. What we'd like for you to do in the interest of time is introduce yourself using the chat feature. Let us know who you are and who you're with. Today's session is a panel discussion on integrating patient navigators into the healthcare team. And this is the third in our three-part series. In March, we covered writing patient navigator position or job descriptions. In April, we talked about patient navigator role clarity, and today we'll talk about team integration. Well, we may do more sessions, but that's going to depend on your feedback. At the end of today's session, Hannah will talk a little bit about an evaluation and a survey to find out how this worked for you and get your ideas on future topics for our supervisors. Okay, so today we'll spend about 30 minutes on a panel discussion. We have three panelists I'll introduce in just a minute. And I should add that we are recording the session. And so for folks who have to drop out or for anyone who wasn't able to attend, they can view it later. So we'll spend 30 minutes, about 8 to 10 minutes each from our three panelists. Then we'll have about 20 minutes for Q&A for the panelists and to have participants share their experiences with integrating navigators into the healthcare setting. And then we'll have about 5 minutes to wrap up. So if you have questions during the panel discussion, please use the chat feature to enter them, and then we'll get to them when we get to the Q&A session and along with any new questions that come up at that point. So briefly, I'm going to introduce the three panelists, just tell you who they are, and then as each one presents, I'll reintroduce them with a little bit of background information on them, just to make it a little easier to track who's talking, what the context is. We have with us today, we're very fortunate to have with us Claire McCardle, who's a social work care coordinator at Associates in Family Medicine up in Fort Collins. Good afternoon, Claire. Hi. We also have Kalisha Crossland. She's a care coordination services program manager at San Juan Basin Public Health in Durango, Colorado. And last but certainly not least is Ronnie Morales. She's a social work health advocate supervisor at Mountain Family Health Centers in Glenwood Springs, Colorado. So we have a lot of, hi Ronnie, we have a lot of rural representation on the panel today, which is a good thing because rural settings are as challenging as any we face with everybody having to do a little bit of everything. So what we've asked the panelists to do is set the stage for us, give us some background and context on the structure, the team structure and their role, the population served, what their approach is to integration, some stories about those efforts, successes, challenges, lessons learned, and recommendations, and then to share any tools that they use, any documents, standard operating procedures, or other tools that they have, and then we'll have time for questions after that. Okay, sorry, I tend to talk fast when time is limited, so forgive me. Our first presenter is Claire McCardle, social work care coordinator from Associates in Family Medicine in Fort Collins. She's a licensed clinical social worker, who works as a care coordinator. It's a large family medicine practice based in Northern Colorado. She leads the patient navigator integration efforts at her clinic location. She also facilitates a patient navigator level 1 fundamentals training for the collaborative. And her previous experience includes working as the medical social worker for Sunrise Community Health in Loveland as a mediator and restorative justice facilitator. Welcome, Claire.
Okay, so I'm going to share my screen, which I just practiced, so hopefully that goes well. Okay. So as David mentioned, I am based out of Associates in Family Medicine, which is a primary care outpatient clinic. We have 9 offices throughout Northern Colorado and over 50 providers at those offices. Our program, care coordination program, began about 5 years ago, and it's gone through multiple different iterations. But where we're landing now is currently we have 9 social workers, MSW social workers at one at each of the offices, 3 quality improvement nurses, and 3 pharmacists. And those roles are split between 3 offices, so they share 3 offices per person. And let's see, we're funded. Our care coordination program is mainly funded through CPC Plus and SIM grants that are administered through CMS, although our providers have said many times over, if those grants were to go away, we would figure out a way to continue with the care coordination program because it's become integral in the way that they practice medicine. So I'll talk mainly about my role as social work care coordinator, but I'll briefly mention the roles of the QI and pharmacist, but welcome questions at the end, and I'll answer them as best as I can. So my role as social work care coordinator is obviously being present in the office. I usually get pulled into office visits rather than having my own schedule throughout the day, although there are times that I schedule patients just with me. Most of my role, I'd say like 70% is addressing behavioral health needs, so crisis intervention, suicide risk assessment, brief interventions to assist with behavioral health issues, and connecting to behavioral health resources in the community. And then also connecting to not just behavioral health resources, but community resources. I do a lot of health behavior change using motivational interviewing, and then some case management of a small population of our high-risk patients that require that and that aren't able to access case management through other services like the MAC team or community case management through our hospital. And again, our role has changed a lot over the last 5 years, and that we've tried to adapt to grants and then to what is needed within the office. But I do think that we've kind of reached a point now where I'm hoping this is kind of where we're at, like this is what we'll be doing for the foreseeable future. Our QI nurses quality assurance nurses and our pharmacists are currently, that's a newer program that's just started within the last year. And they are focusing currently on transitions of care from the hospital to the community and from skilled nursing facilities to the community, and then also diabetes management and prevention. I think their role will expand as they kind of master those areas. So some of the things that we've learned about integrating the care coordination role within the clinic, I think we've learned a lot. So I'll try to get through as much as this as I can in my allotted time. So one thing I like to do and that we all recommend all the care coordinators do is kind of take a moment to prepare for the day. So mornings usually have huddle and then for physicals, and then after the physicals are done is when we start actually getting more acute patients and that have chronic illness and whatnot. So I start the day participating in the huddle and then reviewing who's coming, or previewing, I should say, what patients are coming in, looking at the schedule, making note of folks that might benefit from care coordination services, and maybe having a brief one-on-one huddle with the provider to let them know and talk about how care coordination might be appropriate in that case. Let's see, and then also giving, participating in the huddle at the beginning of the day. So giving announcements or updates to all the staff, including providers and clinical staff. Let's see, the next is communicate roles and projects. And it sounds like you all focused a lot on that at your last meeting. But I think that obviously it's an ongoing need. And I think the main thing that I want to focus on there is to communicate our role, not just with the providers, but with all team members, from the front desk to the call center to clinical staff, because I get so many referrals that are not actually generated by the provider, because a patient will call in, and fortunately our call center knows, oh, I think this actually sounds like something that would be appropriate for our care coordinators, and will direct the call to me or send me a triage through our health medical record system. I also try to communicate our role through emails, and then participating in monthly staff meetings for our office. And I think the next, really utilizing team-based care, really speaks to making sure that you're communicating with all members of the team, not just the providers, so that they understand what our role is, and that we can help in it when they're feeling stuck. So using policies and procedures to increase referrals, I sent some forms over to Hannah to share with you all that we've started to use to kind of standardize times when referrals to social work or care coordination might be appropriate. So 2 examples of that are doing screenings with patients. We do a depression screening using the PHQ-2, which turns into the 9, which is a patient health questionnaire, but it's basically a screening for depression. We administer that, our clinical staff administers that annually to every patient, at least once per year. And then if the patient scores high or states that they have thoughts about harming themselves, then that will be an indicator to the provider that might be an appropriate referral then to care coordination. And the other screening tool that we're utilizing is what we've developed as a social determinants of health screening. We've used questions that are in EPIC, which is the electronic medical record system that we utilize to create this screening. We've selected points that are areas that we feel like we could actually make an impact, or that there's resources available. And so the clinical staff, again, provides this to patients who score within a certain risk score range. And then if they, through completing that survey, identify areas that they are lacking resources, then that would generate a referral again to the care coordinator to provide resources and assistance in accessing those resources. And I sent both of those forms to Hannah to share with you all. So let's see, we also work to educate new providers about our program. So each social worker at their home office has about 30 minutes with new providers during their orientation to talk about our program, our role, answer any questions, find out how they've utilized care coordination in the past and how it might be similar or different at our particular agency, and to start building that rapport from the very beginning. And then the other piece would be, my other piece of recommendation would be to identify formal or informal provider champions within the office. So finding those providers that really believe in the program, and even asking them if they would be willing to kind of share success stories with their colleagues, or kind of talk up the program a little bit. And then I think role definition, it sounds again like you all really covered that last time. I did send to Heather a one-page form or document that we provide to providers and to clinical staff that gives an overview of who does what within the care coordination team. So the QI nurses and the pharmacists and social work, to help clarify those roles. And my last bit, let's see, I don't know where I am on time. I'm good, Hannah? Okay. So then my last piece is some of the lessons learned. So being flexible is something that I think we all have to learn how to do within the healthcare setting. It's something we're dealing, change is inevitable. And that's true for the care coordination role as well. So just being vigilant and aware of the needs of the other staff members, when I'm meeting, for example, when I'm meeting with a patient, if a provider's asked me to meet with a patient, I'll typically check in with the provider first and say, okay, do you need this room? Should I move the patient? Doing whatever I can to limit my negative impact on the provider and their schedule so that I'm only improving their flow and not distracting from it or causing issues for them. And so sometimes too, it'll be a matter of just meeting with the patient, doing kind of a warm handoff referral to me. So I have that face-to-face interaction and do kind of a capability statement of here's what my role is with you. And we're going to follow up over the phone in the future, or schedule another time for you to come back if that works for you. Let's see. And being considered, I think that kind of is tied into that point. And then finally, making sure that you're visible. So I think at the beginning, we were doing a lot of home visits actually, which I think is good work. But then providers were starting to question, well, where are our care coordinators? They're never here when we need them. And so we've actually moved away from home visits and more towards in-office visits, just so we're available for more patients and always visible to the staff. Another tip is that we've put a whiteboard on our office door that gives information about where we are. Not that people are trying to like keep tabs on us, but it just is helpful to know, oh, they're at a meeting for work right now. Or if I have to come in, late because I have a personal appointment or whatever, they know, oh, she's going to be here at 9. We also use Spark, which is like a chat room. I don't know what the right, but you can chat back and forth with folks. So always being on Spark and available that way. So even if I'm with another patient, I can let the provider know I'm with another patient right now, but I'll be available in 10 minutes or whatever it is. I think helps increase our visibility and know that we are available to them. So that is it. That's all I have to share, but I welcome any questions at the end.
Thank you, Claire. And I see questions coming in, and we will get to those before the session is over, including caseload volume for each person. Okay, so Kalisha Crossland, again, as I said earlier, is a Care Coordination Services Program Manager at San Juan Basin Public Health in Durango. She worked in local public health for 5.5 years. She originally started as a case manager for Options for Long-Term Care. She's worked as a healthcare coordinator as well as a care coordinator, and she moved into management, lucky Kalisha, about 3 years ago. She currently manages a team of care coordinators in local public health in Durango. Thank you, Kalisha.
Hi. Okay, I'm attempting to share my screen. Let's see here. How's it going with this? Okay.
Yep, there you
In
go.
there? Okay, let's see. Sorry, guys.
Just go from beginning on the far left there.
All right.
There you go.
Okay, great. So thanks for having me. Just to give you guys a little bit more information who are on the call today. Like Dave said, I've worked in local public health in a couple different arenas. Started as a single entry point case manager, worked as a family health coordinator under the Healthy Communities grant through HCPF, and then moved into care coordination under our Rocky Mountain Health Plan's RICO funding stream. All of these positions, with the exception of the single entry point case manager position, were on the care coordination services team at San Juan Basin Public Health. So that team is a large team that really incorporates a variety of care coordination programs. So, and let me back up, actually, I'll give you a little history of care coordination at our organization in general. We started as a community care team about 13 years ago. A nurse named Suzanne McInnes was working at San Juan Basin Public Health and really started to find that there was a gap between the information that clients received at an appointment and how they implemented it and the follow-up. And so that's really how our program started in local public health in Durango, from my understanding. It was funded by the hospital, a couple different providers in town that really believed in this service. So Since then, our program's funding streams have evolved to be supported by state, federal, and local funds as well. So just a little history on the gaps that we fill and where we started. So here's my lovely team. There's a variety of skill sets on this team. My supervisor, Dr. Laura Warner, has a master's in public health and is a retired MD. We've got nurses, we've got oral hygienists, and we've got some lay people on our team. So we've got a variety of skill sets represented. And let me turn on my chat to make sure I can, okay. So our team structure is, we've got a couple different programs supported on this large team, and a lot of people work in multiple programs. And I'll get more information. Oh, so we always like to start with the definition of care coordination, like how do all these different programs fall under one umbrella? So this is what we're all trying to do. That's our underlying goal of all of the programs that we serve. And our organization's mission and core public health values, as far as how does this fit into local public health? Because our agency believes in the fundamental right of each individual to obtain their highest level of health. Because I think it's always important to know why something lives in a different arena. Like, why aren't we in a doctor's office? Our mission statement in local public health to protect and inspire health in our community through these different mechanisms, through stewardship, compassion, health equity, integrity, and respect. So these are all values that you'll find through all the programs that I oversee. Okay, so the different programs represented on my team are MCH HCP, which is maternal child health. This program is run by a nurse and a nurse coordinator. Really, we're working to identify the access to specialty care component of care coordination, working with children and youth with special health care needs. We also have a TANF nurse, which is an acronym for Temporary Assistance to Needy Families. Again, working with parents, working with families, working on vocational support. We've got a regional oral health specialist. Again, blended funding, working on educational outreach in schools throughout the communities. She's specific to navigating dental benefits. We've got our family health care coordinator, who is also a blended funding combined position. So she's doing benefit education, outreach, Medicaid enrollment, and then working to identify the gaps in care from the prenatal standpoint. So we're really working upstream on this. And then we've got our largest representation, which is our RICO funding, so the Regional Care Collaborative Organization. So we're RICO Region 1, a variety of nurse navigators with specialty skill sets, as well as care coordinators. We also support a integrative position that is a single entry point position, as well as a care coordinator. If I could back up for a minute and really just talk about, our team-based approach to care. So this is really a value of our program. You'll hear a lot about team-based approaches, but we work with so many different key performance indicators that we try to match them with the different staff that we have on a larger scale team. So to be more specific, we've got a B4 Babies coordinator that receives funding from Rocky Mountain Health Plans that also is working under a Healthy Communities grant. So we're really trying to match the client base that this person may already have, as far as the clients that they're really positioned best to care coordinate for, and match additional funding opportunities to create sustainability within that program or within that position. But so we're capitalizing on individual strengths. We're collaborating in group settings, really working to enhance the outcomes for our community's health. The amount of clients that we serve is a little bit larger of an amount for the area that we live in because of the combined programs and the combined funding streams. So I think that really is unique to our agency, is being able to match dollars, being able to have flexible funding to support a general key performance indicator or general scope. We also have a regional oral health specialist, like I'd mentioned, that works directly in schools, as well as doing outreach and enrollment. We realized what a great skill set she had in regards to already working with a vulnerable population. And so we added some funding and have her, really doing dental navigation, a specialty skill set. So although we have a small but mighty team as far as the amount of populations that we serve. Some of the things that help us perform well in this rural health setting are our partnerships. We've got strong partnerships with our hospitals, different providers, specialty care providers in the area. So that's something that's a big strength of ours. And being in local public health, having this historical background with these providers really leverages our positioning, helps us to communicate better. We've been working with them for years. Another advantage of our team is that we have a lot of access to local EHRs. So all of our nurses, all of our care coordinators are able to access individuals' records if need be through the local EHRs. We also, I'll talk to you a little bit about some of the challenges of integrations. Having some of these, having these programs supported by so many funds is a challenge because we've had to, our staff has to answer to a lot of different funders in regards to reporting. 2-minute warning. Okay, great, thanks. Short time frames to measure successes, that's another challenge. A lot of these integrations that we've done as far as matching different people with different key performance indicators is that we haven't had a lot of time to show the quality of work that we've produced in our area. A success is that we're serving a lot of clients in a more efficient, effective way instead of having this client go between multiple agencies. They're being served within one agency or within one position. So that's definitely a strength, especially of our elderly. Didn't tap upon it, but I think it was pretty obvious that our client load is, high volume. We serve age ranges from womb to tomb, we say. So from prenatal to elderly clients in our community. So sustainability plan is that we have so much supportive, flexible funding. We are able to do a Tetris of adding different fundings to different skill sets within our team to keep them sustainable. So.
Did it?
That's it.
Okay, cool. Thank you so much. I'm going to break my rule about leaving the questions to the end because I think this may get lost. So what is each navigator's caseload volume in yours? And then I'm going to ask Claire the same question.
Right, thank you. So each navigator, since all of our funding streams are so different, it really varies. And it also varies on the type of work that we're doing. So our nurses and care coordinators that are performing intensive case management, like really doing full-blown, 100 question assessments, social determinants of health with people with complex health needs, we try to keep those realistically at about 8 to 10 per full-time 1.0 FTE. And that's because it's so intensive and it's not the only thing that they're responsible for doing.
Okay.
So those caseloads are like really for our complex clients. It's not to say that, that slide that I showed of the thousands of people that we serve aren't necessarily in that capacity.
Okay, thank you. We'll find out from the person later, from the person who asked the question, whether they got that fully answered. Claire, what about in your organization, the caseload?
So because we have a lot of different roles that we serve within the clinic, it's not super clear cut, but we generally have a caseload of care managed patients of about 150. So those are folks that we're kind of doing ongoing work with, but not all of them are intensive. I would say there's like 10 that are more, you're more involved with at any given time, or we call them lifers, that they're going to be the folks that we probably are going to continue to case manage for a long time. And then there are folks too that we see maybe just a one touch, connect them to resources, and then we don't enroll them in case management. It's more just, here's the information you need, here's how to access it. We feel like they have the activation and agency to be able to do that, and so that's not included in the 150. And then each clinic varies in size, so anywhere from 4 to like 8 providers, which each provider has a panel of probably 13 to 1,500 patients, which in theory could become our patient. So in my office, there's 5 providers, so that's about, we'll say 5,000 or 7,000 patients that are kind of could be within my scope.
Okay, thank you.
Mm-hmm.
All right, Ronnie Morales is a social health advocate supervisor at Mountain Family Health Centers in Glenwood Springs. She's also a medical assistant who began her career with Mountain Family as a patient navigator. She's also one of our trainers at the Patient Navigator Training Collaborative, and she supervises other social health advocates, and has, like the others, has her own caseload as well. Ronnie, take it away. You're on mute.
Okay, you guys should be able to hear me now. Thank you for inviting me. And just a little bit of background from Mountain Family Health Centers here in Glenwood Springs Community Health Center, and I've been with them for 8 years. And like David said, I started off as a medical assistant, then started off doing patient navigation for disease management populations. And then from there, our care coordination department developed about 4 years ago. And so being at the forefront with another provider and another nurse, and seeing the expansion to where it is today. And then one of the things that I definitely take pride in Mountain Family Health Centers is just our mission to provide high quality integrated primary medical, behavioral health, and dental health to the communities we serve, with special consideration to the most vulnerable, regardless for their ability to pay. And I'm going to go ahead and try to see if I can share my screen here. We'll go to that one. Okay, perfect. Okay, so it's awesome to hear the 2 other facilitators share a little bit about and I feel like a lot of our work overlaps. So I'm going to try to go through my slideshow briefly here. So here is our team, and just like Alicia had said, this was at our team building that we did last summer. Lots of different levels of experience and skills and backgrounds in our care coordination department. We have our nurses and our medical assistants that work hand in hand to really work with other care teams, like our nurses, our medical assistants, our providers, behavioral health, and our dental teams, as well as other external staff members to really help wrap around services around the populations that we serve. And so with our integrated care model, we really are trying to focus on that synergy of care teams' quality improvement, and trying to see where I hear a lot about like who takes lead on what. And so really case conferencing, not just with internal staff members, but also external agencies, to see what patients we have that might overlap, and that we can all kind of collectively work together to help the patients better navigate our healthcare, our complex healthcare system. We really have adopted the triple aim from the IHI, which is the Institute for Health Improvement. And because we've been for the past 4 years, really been at the kind of just developing, not trying to recreate the wheel, but just trying to see what has worked in the past, what are some of the challenges we're facing in our community, especially with funding, and how can we kind of just bring it all together. So definitely our department is funded by Rocky Mountain Health Plans. Primarily we work with patients from the Medicare, Medicaid prime population, but really we were called into action to improve not only the reducing the cost of those ER visits and admit visits, but trying to focus on improving that patient experience. We're really big on storytelling, improving the health of the populations that we're serving, reducing that per capita cost, and of course, we really focus on staff satisfaction, making sure that the people that are in our departments have the tools and skills that they need in order to be able to provide the best quality care that they can. In our department, we really have focused on our patient, our client, however you may refer to them, but really embracing that socioeconomic, educational, behavioral health, everything having to do, like the client, the patient is the hub, and really trying to figure out meeting patients where they're at. And so one of the things that we have done is we're really lucky to have our behavioral health department integrated in all of our facilities. And so my department and behavioral health always kind of get together and conference on patients, again, that might overlap, but also with the providers. We also do a lot of case conferencing with Mind Springs, Northwest Colorado, Options for Long-Term Care, and just trying to see who's got the patient, why the patient is struggling not only with their chronic condition, but what has the patient expressed as far as what are their challenges with some of those social determinants, transportation, housing. Sometimes a lot of it is helping them out with going to the Department of Human Services because benefits have been interrupted. And so one of the things that I really wanted to talk about today, and I'm going to go through these slides because I feel like this breaks it down more of every single site, how many staff members we have per site. And I really wanted to focus more on the structure of our department. It'll let me go to that slide. There it is. Okay. So our social health advocates, our title has changed so many times. At the core of it all, we're patient advocates. We are patient navigators. And what has been really successful about this department is we have our nurses that do that high-level acuity care, case management, care management, and then we have our social health advocates that really focus on the basic level would be health education. So providing health education to all patients, regardless of payer source, on diabetes, hypertension, cholesterol, obesity, and tobacco cessation. These services are completely free, which is great because one of the biggest challenges for patients that are not able to have insurance coverage is if they need any of these services and get referred out, a lot of the times follow through isn't there because they're not able to afford the cost. So for us to be able to provide these services in-house when people are diagnosed or if they need ongoing self-management support, our social health advocates are able to do that. I know I heard you guys talking about caseloads. Our social health advocates, when we're managing a disease management population, we manage 100 patients per social health advocate. And that is an ongoing service. There's about 4 to 6 sessions per patient, but it's really following that patient with that provider, making sure that they're coming in for those follow-ups, checking in with them on the phone, using MI skills, and really coaching them on healthy lifestyle changes. So health education is a big component of social health advocacy. The other big component is transitions of care. That means that anytime any of our patients are going to the hospital for whatever reason, we get notification via QHN portal. And so that lets us know that a patient has been seen and we are contacting them within those 48 hours, making sure that patient understands their discharge instructions and that they have appropriate follow-up care back to their PCP as needed. We also make sure that, of course, if they need to be triaged, that happens with one of our nurses. And if they have to be seen with the specialist, also making sure that we bring them back first to the PCP to make sure that we minimize those gaps in between care. Anytime any of those transitions include behavioral health gets tagged to make sure that they are aware that that patient has gone to the hospital as well. Our complex care nurses do that next level of care. And one of the things that I feel has really worked between licensed and non-licensed staff is the ongoing support from our director as far as training goes. I can't say enough about training, mentoring, and fostering professional growth for non-licensed professionals, because we want to make sure that everyone is working at the top of their scope. So a lot of when we have our meetings, it's not just a meeting to check in and talk about, where we're at. It's also work sessions. Going back to the drawing board and talking about, what are the social health advocates responsible for, depending on the grants, what our numbers need to be, but also how can we best support the nurse team. So having our nurses also do some training around things that can be handed off and delegated to social health advocates, so that nurses are doing what they need to be doing without having to do other things that can be handed over to non-licensed staff. Caseloads for nurses. So I think this is probably one of the most frequent questions we get. Our nurses, ideally, per case management, 30 patients per nurse, right? But the reality is our nurses manage 50 to 75 patients per nurse right now. And so that's an ongoing discussion based on what our measures and our deliverables need to be per our funding. And so just coming back and also hoping that we get funding for more staff members. But in the meantime, just trying to see where our nurses are being best utilized, and then again, what can be delegated to our social health advocates. And all of our social health advocates, part of the training process, a requirement is when they are hired, we're looking for social health advocates that have 1 to 2 years MA experience. And we also make sure that they understand the work that they're going to be doing now. It's that next level of care. So not so much hands-on with the patient, but more administrative, case management, care coordination, social work type of environment. We also make sure that they are required to do within their very first year of employment, they have to have patient navigation fundamentals level 1. As they continue with their growth with us, we encourage and we support patient navigation training level 2s. It just really depends where they're at as far as their developmental growth as far as with the company. The biggest thing that I feel has been really successful for us, though, is, again, those work sessions, bringing it back to the team and seeing how we can match the work that we're doing, making sure that we have proper standing orders in place, making sure that people have really good role clarity, that job descriptions. One of the things that we created this year was based on the job description, just transferring that onto a simple Excel template to kind of make a checklist so that for those of us that are overseeing staff, we can check up on those skills. And that's really important. Every 3 to 6 months, it just really depends on the particular staff member. Monthly check-ins, one-on-ones, and also we have right now we're having weekly staff meetings. Clearly, as things get a little bit more settled down, we space those out. But constant communication about how to better improve our roles, period. And then, of course, I think the mentoring has been huge. What are the nurses doing? If they have an opportunity to go to different forums, different trainings, bringing it back and doing a teach back to the team. And same things with social health advocates, having that accountability piece, coming back and seeing where we sent them off, what kind of training they got, and bringing it back to the team and then incorporating it into our current workflows. Okay. I think I've covered a lot of, because I feel like the two other presenters covered a lot of things, and I didn't want to go so much into projects that we have, but I think the biggest thing that, again, and you know, Claire brought a lot of challenges that are so relatable. Visibility, yes. You know, at every site we try to have our care coordination office. We try to go to huddle in the morning along with the care teams, but also checking in. We have our own schedule set up. Sometimes patients will come and see us only, or sometimes we'll see them while they're here with the provider. But just having that constant communication and being visible to those teams and saying, we're here if you need us, I am us, or us saying, hey, I'm going to see your patient at 1. The other thing is, when it comes to our patients, I think what has come out of this department in particular is really the powerful stories about the non-existent, non-compliant patient, and really bringing to how do we best support our providers with their recommendations, but also advocating for our patients and teaching our the rest of the people that don't work in care coordination how we connect to resources, how certain benefits work, how do our patients get their information outside of our clinic as far as their benefits go, what resources are available and for whom, making those strong relationships with our partners, our community partners like the Department of Human Services, the hospitals, and being able to come to the table and have case conferences so that we're all discussing the same people that live in our community that we're all serving and who's taking lead on what. What has come out of that I'll give you an example based on our transitions of care. There was this big thing about patients going to the ER for, possibly narcotic seeking behavior. Because of the communication between Valley View Hospital and Mountain Family Health Centers, we were able to then meet with their crisis team, have monthly case conferences, and now the patients that would go to the hospital specifically for narcotics, we were able to share the medication contracts that they have with us. So if the patient showed up to the hospital, whatever rounding provider they were being attended by, that provider had access to that medication contract so that they would treat them, but then send them right back to us, to their primary care. And so it's all these tiny little things that have been a kind of identified just through the process of it. But when I think about the individuals that work for this department and the kind of support that really makes an impact, I think about the ongoing training, having workflows in place, having job descriptions. I know that some of us rely heavily on HR for that, but having a really good look at that and seeing, what, according to the job description, what does the funding say and how do we merge that together? And what kind of training will these staff members need and what kind of ongoing support and what needs to be in writing? So for liability purposes, especially for non-licensed staff. And then also, how can non-licensed staff work at the top of their scope supporting our nurses, and what can the nurses delegate to kind of even out the workload?
Thanks, Ronnie.
Thank you.
Yeah, I'm hearing some common themes, but I want to make sure Melissa Zahn got her question answered about caseload. So, Melissa, if you're still on the line, do you have any follow-on questions about caseload? You're muted, so we can't hear you. Okay, so I heard some common themes in here. Continual collaboration, I think, is sort of at the top of the list, that on a daily basis, people are collaborating. In this regard, I heard the trying to tailor the navigation service to the needs of individual providers, not interrupting their flow. And I heard champions. So I heard Ronnie talk about the director being a champion of the program, the navigation services, and the development of those people. Claire and Kalisha, well, Kalisha, you're in management, so you are one of the champions. Are there other champions that you think are pivotal to integrating navigation into the team?
Definitely, and I didn't specify. I still carry a caseload, depending on my capacity. So that's just something that's really important to me that I would never give up, even though I don't have as much of bandwidth as my team. So, as far as champions, my director is also wonderful as far as providing different opportunities for growth and making sure that our name is out there. I think a disadvantage of our community, since our community care team has been around for some time, we don't have really refined boundaries, and sometimes that can be confusing to our community. So we're easy to access. Everyone knows that we are what we do and who we are and who we serve. But as far with the influx of different supports, like different community health workers or patient navs being added in different positions, our scopes have been refined. And so for us, that is one little disadvantage that I didn't touch on, is that we have great visibility, but it's not always clear on exactly where our boundaries are and where our scope ends or begins.
And so, again, I apologize if I'm making you repeat yourself. How do you handle that in terms?
Constant communication, meetings, meetings before meetings, meetings after meetings.
Seems like there's no substitute for that in this business.
If you find one, let me know. But I think when it comes down to it, meetings, communicating with our community partners, messaging. Our agency's been really working hard on messaging for different programs. So we've just implemented in the last 2 years a communications department within San Juan Basin Public Health. Mm-hmm. So they're able to meet with all of the managers, talk about the different, responsibilities of our contract, different highlights of our program, and how we can message that clearly to our community.
Great, thank you. Claire, who are champions in your organization for navigation?
Well, I think our medical director, or our CEO, I should start with, actually is a huge advocate, so that helps for sure. He is very supportive. We have, apart from the care coordination department, we have like a patient-centered medical home quality improvement department, where a lot of the care coordination services kind of overlap with that. And so our quality improvement manager is a huge champion. And then within the office, there's, providers that I think just somehow, like, they get it. I don't know how they get it, and others don't, but they do. It seems to speak to them somehow. It's more intuitive to them. And so just having those conversations with the individual providers about, kind of giving them a little bit of kudos for, you really get it, and then asking for them to help support you is something I've found to be really helpful.
David, can you
Yes.
hear me?
Yes.
I think one of the big learning curves for us has been that sometimes it's the boots on the ground that kind of get things going. And so sometimes we wait for these meetings to happen between us and other agencies. And sometimes we realize that it's the boots on the ground that kind of make it happen. Big fan of the Department of Human Services, working with this population that's so complex, and having such high turnover in our work here in the health field. How do we best? What ended up happening? We were just having so many challenges. Our patients having services interrupted. It finally dawned on us that we shouldn't wait for the big people to make a meeting. Let's invite some of these case managers over and their supervisor. And now we meet on a monthly basis. We were able to, the Mountain Family and the Department of Human Services for Garfield County were able to vote on a best way of communicating, so that whenever we have a patient here and we need to find out something immediately about their benefits like transportation, we actually have a go-to person assigned per patient. And that has improved drastically. I mean, we're getting answers in real time and vice versa. And just kind of getting to know what their workflow is like, what our workflow is like, and that we're in this together. The work of case managers, care coordination, whatever you call yourself, is really hard work, but it really does take a village. And to be able to come to the table to talk about similar challenges and come up with some solutions, we really have come up with some great solutions moving forward that we see like, why did we wait this long? We should have had this meeting should have happened a while ago. And it's because sometimes we get stuck on, well, who needs to make it happen? It's like, you can make it happen. It can be you. So I think sometimes we get stuck on that.
So we have, I think, I don't see any new questions in the chat here. So how do you, oh, here's a question from Reed Bryan. Ronnie, can you discuss how patient health navigators integrate dental as one of the resources for patients?
Absolutely. So dental can be, we're one of those community health centers that in one of our locations, we have dental services in the actual building. We also have a dental mobile van. So our dental department has a manager, and we go, it's still in the process because our dental assistants, they don't work SMA, so it's a little bit different. But one of the biggest things that came out of this was, for example, our Medicare patients or even Medicaid patients have certain monies allotted to them per year in order to get dental services. So when we have patients with dental needs, it's coordinating like, oh, maybe that fiscal year is about to be up for that money and it's not going to go into the next year. So how can we coordinate these appointments for the patient with this particular provider? So it's working with those, with that manager and that dental provider to see how we can best fit that patient to come in and get the services that they need before they lose that benefit. The other thing is we have a SMILES program. And so whenever health educators are meeting with patients, and it has to be about health education around nutrition for the family, it's also promoting preventative services for dental hygiene.
Great, thank you. So we have about 3 minutes left. You guys are sending, our panelists are sending us tools that you use, like process flows or anything like that you have to help everybody understand how the Navigator fits in?
I've got a couple workflows that I can share for sure.
Okay, that'd be great. And then do you have any final thoughts, just really briefly, on how you promote the successes of the team so that people know that it's working and they deepens their buy-in?
I think in general, our agency's communication team is really supportive of all the programs, giving them, equal time to share their successes. For our community, where the buy-in comes from, since we're an external community care team, so our buy-in and our viability comes from the providers within our community that speak highly of our team. And so, I don't know a better way to message a product, so to speak, than to have the our providers in our community, our hospital in our community, bringing us into more and more meetings, asking for more and more of our time because what we're doing works.
Great, thanks. Claire?
So I think, again, like with meetings, we present annually at our provider meeting, and our company is provider owned, so they're the provider owners, and present the successes and growth that our team has experienced over the last year. And then just, again, communicating in like monthly staff meetings with all staff on what's going on, what's new. So they're always aware, and we're sharing our successes with them as well.
Ronnie? Last line.
Yes, so definitely at all staff meetings, which happen monthly on the first Tuesday of every month. But one of the genius things that our director did is she actually has a newsletter for our department. So even we don't have to wait for the all staff meeting. This gets kind of posted. It's kind of like a little bit of a blog. And so we share there our successes, our challenges, what we're currently working on. And then as a professional storyteller, I really believe in the power of stories. And so anytime that me or my colleagues have an opportunity to show up at different forums and share some of these very impactful patient stories, we definitely take that opportunity to make sure that people's voices are heard, and how much our goal is for these services to be provided to all patients regardless of payer source.
Great. Thank you so much. Okay, we're out of time. Hannah, can you just briefly talk about the survey? We'll send out an evaluation, and be thinking about other topics you would like for this series for us to present.
Yeah, you basically covered it. I'm going to send a survey link here in the chat. It should take you less than 5 minutes, and I will also email it to everybody. So whichever way is easiest to complete it, we would really appreciate the feedback.
Great. Okay, thank you to our panelists. Thank you so much for the time and energy. We know you all are very busy. Thank you so much for taking the time to do this. Imagine a round of applause now. I'll visually demonstrate the round of applause. We really appreciate that. And for everybody else who's still on the call, we will send out the handouts, the tools that the panelists provided. Thank you all so much,
Thank
and
you.
keep up your good work.